My name is Dr. Hakan Paydak. I'm a professor of medicine at the University of Arkansas for Medical Sciences, and also I'm the director of the Clinical Cardiac Electrophysiology program. I have just presented at the International Academy of Cardiology Annual Scientific Sessions 2018 that was held in Boston. My topic was unusual causes of unusual arrhythmic cause of syncope. These are the 9 cases that I've collected over the last 20 years at 2 different institutions. The first case that I want to present is a patient with complete heart block in the setting of right bundle branch block and left anterior fascicular block and first degree AV block. This patient came with Möbius type 2 second degree AV block, and these 3 patients all had syncope, and we put them on the schedule for the next day for a permanent pacemaker implantation, but all 3 of them developed complete heart block overnight, and 2 of them received permanent pacemakers, and 1 of them had a temporary pacemaker and then received a permanent pacemaker the following day. Arrhythmic cause of syncope have been reported, cardiac causes have been reported to be 18% in a study that was published in the past. And the problem with the cardiac cause of syncope is it doubles the mortality risk in the long term, and it causes a lot of anxiety and depression for the patients and loss of work time. The second case that I want to present is a case of Brugada syndrome that I had encountered when I was an intern about 20 years ago at Illinois Masonic Medical Center in Chicago. A 41-year-old patient presented with syncope and seizure-like activity, and we found that he had classical type 1 Brugada EKG pattern. At that time, we asked for family history. It was negative, and we did an electrophysiological study to prove that he had easily inducible ventricular fibrillation, and with doubles only we induced the ventricular fibrillation, and we implanted a single chamber ICD, and he has not had any therapies in the follow-up. The third patient that I encountered was at the Medical College of Wisconsin, when a 74-year-old patient presented with complete heart block, an injunctional rhythm, and the patient became confused and he received haloperidol in the emergency room, 2 milligrams, which led to torsade du poing, and the patient passed out and had cardiac arrest and had to be defibrillated. And since the patient was defining angina and had some ischemic EKG changes, we did coronary angiogram, and we found a 90% lesion in middle AD, and after doing percutaneous coronary intervention, the patient's complete heart block resolved, and he has not had any further episodes of heart block, and he was discharged home safely. There were 2 other cases of torsade du poing, one of them with a common drug similar to haloperidol, methadone, in a 31-year-old patient who was a recovering drug addict. And she was on maximum dose of methadone at 60 milligrams twice a day when she presented with multiple episodes of syncope. Her QTC was prolonged, her potassium was 3, and we recommended to replace the potassium and consider switching to another medication rather than methadone. But the patient continued to have syncopal episodes, and during video EEG, we documented that the patient indeed had ventricular fibrillation and torsade du poing, and that spontaneously recovered. And we switched to bupreponium, another medication which can be used rather than methadone and doesn't prolong the QT interval. And this patient did not have any further episodes of syncope in the future. The other case of torsade du poing happened surprisingly with a class 1C medication called Flecainide in a patient with persistent atrial fibrillation. We beautifully controlled her arrhythmias at 150 milligrams twice a day of Flecainide. And she had sinus node dysfunction. That's why we stopped her digoxin and AV nodal blocking agents. She and her husband went to a gambling junket in Mississippi. And she had an episode of awakening from sleep with garbled speech and loss of consciousness. And we overflight the patient from Mississippi to Arkansas, and in telemetry we detected that the patient had 3 episodes of torsade de pointes and ventricular fibrillation overnight. We did a heart cath and then implanted dual chamber ICD and restarted Flecainide, and the patient has done well since then. Retrospectively thinking, maybe we could have also gotten away with a dual chamber pacemaker, but we had a visiting professor at that time, Dr. John Miller from Indiana University, who suggested it will be safer if we implanted dual chamber ICD, and we proceeded with that. The 5th patient that I want to present is a 40-year-old African-American man who came with recurrent syncopal episodes with neck movements. And we detect that he has a neck mass, and it was applying pressure on the carotid body and causing sinus pulses up to 5 seconds. I had heard from Dr. David Bendit from University of Minnesota years ago about beneficial use of using theophylline in activating the sinus node and facilitating conduction over the AV node. And we empirically started the patient on theophylline, and the patient did not have any further episodes of syncope or sinus pulses. And 1 year after treatment with radiotherapy and chemotherapy, we stopped his theophylline, and he did not have any further episodes of syncope. The 6th patient that I want to present is a patient who was a young woman with mucolipoidosis 3 or pseudo-Hurler dystrophy, who had multiple orthopedic surgeries. This is autonomic recessive disorder, and the patient was having syncope and pre-syncope with non-sustained ventricular tachycardia episodes. Initially, we normalized things with sotalol, and ejection fraction improved. But later on, her mitochondrial disease progressed, and despite the fact that we changed her to amiodarone and implanted a single-chamber ICD, the patient developed severe congestive heart failure and died later on. The 7th patient that I would like to present is a patient who had atrial fibrillation again and was referred to me for treatment. And we placed the patient on sotalol, but he had significant sinus bradycardia. And then at that time, we couldn't go for AFib ablation because they need to fail at least 2 antiarrhythmic agents. And when we admitted the patient for dofetilide loading, the patient had a white complex tachycardia. There were 3 electrophysiologists who were baffled with the nature of this white complex tachycardia. It could be VT, it could be AFib with aberration, or it could be pre-excited, but pre-excitation was intermittent, if any. And when we brought the patient to do a pulmonary vein isolation and also electrophysiological study to determine the etiology of the white complex tachycardia, we found out that the patient indeed had Wolff-Parkinson-White syndrome, and by ablating the left lateral accessory pathway, his symptomatic atrial fibrillation has disappeared off all medications, and he had only 30-second episode of atrial fibrillation, which was asymptomatic during sleep in the 30-day event monitor. The last patient that I want to present is also interesting. 68-year-old woman who came with syncope recurrent, and by history I thought she may have neurocardiogenic syncope. I did a tilt table test, and needless to say, she had neurocardiogenic syncope, but she said her episode was a little bit different than what normally happens. She had underlying normal sinus rhythm with borderline first-degree AV block and left bundle branch block. And then she was started on anticonvulsant therapy with no benefit. And when she was brought in for video EEG, we detected that the patient indeed went into complete heart block when she had one of these episodes. And I personally rushed the patient to the OR and implanted dual-chamber permanent pacemaker, which fixed all of her problems, and she's not on any anticonvulsive therapy anymore. We tell our medical students and residents and fellows that the best way to diagnose syncope is by getting a history, but all these patients that I've presented today, we had to use a EKG monitoring modality to diagnose. The two cases we detected by telemetry monitoring. Telemetry monitoring may have a yield of as low as 16%, and we can't keep the patient on telemetry for longer than 24 hours. And only if we think that the rhythm problem that has led to syncope is dangerous for the patient, we can utilize this modality. Holter EKG has very low yield, 1 to 2%. Unless the patient passes out on a daily basis or twice a week, it's not very helpful. The other modality that we can use is a 30-day event monitor, which has low compliance by the patient and cause some problems with skin sensitivity and etc. But if a patient is having episodes, not every day, but maybe once or twice a week or so, or once or twice a month, that's a modality that we can use. And finally, according to 2017 ACC, AHH, HRS, and ESC guidelines, implantable loop recorder can be used for diagnosing arrhythmias, even though it can't treat, if the episodes are happening less frequently, more than a month or apart. So I hope you also have learned from these 8 or 9 cases that we have published and presented at international meetings, and you benefit from the experience that we have had over the last 20 years.